respected chair, respected teachers, Dolly ma'am and Dr. Handu, from whom I have learned a lot during my learning phase and still learning. And uh, the whole Actimos and Medical Trust team for inviting me here. Especially I would like to congratulate Antonio for the effort he has put and wish him all the best. So coming to epitope matching, basically I'm still learning the whole of epitopes and so I'm a student. So it's just like a discussion, and I think Siddharth and some speakers in the morning have discussed epitope in their talks, and that has made my this thing very easier. But as a clinician, what can we take home at this point? Because these informations are flooded into our into us from the lab. So that is where I will try to focus on. So we all know that HLA is a protein made up of amino acids, and if you look at, like we are like 200 people here, it's highly polymorphic molecule, none of us will be having similar HLAs, okay? But if you look at the HLA molecules, there's a lot of homology. You see more dots and dashes there rather than the alphabets. So these islands of polymorphic amino acid residues which you see as the alphabets are actually the epitopes, and that is what gives the antigenicity and develops the immunogenicity of an HLA. So each HLA is around like 200 to 300 amino acids, and according to the position of the amino acids, you know that there are like 20 alphabets denoting these amino acids, and that's how we name the epitope as such. So at the end of the day, the antigen-antibody reaction is nothing but a epitope-paratope reaction, where paratope is the complementary thing that we see on the antibody. So, but just like Siddharth discussed in the morning, the whole area, the epitope area is called the structural epitope, where actually inside the structural epitope we have these hot spots of activity, which we call as the functional epitope or the epaulet. So many a times we can see the epaulet and the epitope being mentioned basically, and this is how the geographical lie is like. So at the end of the day, when an organ comes, an antigen comes, what the immune system sees is that it is a mix of certain scattered epaulets or functional epitopes. So now this is the traditional HLA antigen matching that we discussed. I think Siddharth told it in the morning. But now we have to disconnect from what my A, B, C, D are, loci are like, and instead that we populate it like this is my HLA. It is made by like a discrete set of certain epitopes, and when a foreign organ comes, it has its own discrete set of epitopes, and what my body looks is that what is foreign in that, and if it is immunogenic, I will try to make an antibody against it. So this is the concept. So I think this is an old slide. Siddharth showed like 41,000. Okay, so it's like 40,000 alleles, and with the molecular and the sequencing that is happening every day, it is coming daily new things. So what is the fascinating thing of epitope? When you slice it to end, this class 1 27,000 alleles is nothing but mix and match of 252 epitopes. So this is the fancy thing that we fancy about. It is, instead of matching for like 21,000 alleles, 27,000 alleles, it might be easy that we can match for 250 epitopes. And further, if we go, there are like 5% of the epitopes are seen only in one single allele. Okay, another 5 to 10% is seen like in few alleles, but 85% of the epitopes are seen in multiple alleles. So it is very difficult to find a way between this, and that is the challenge of epitope matching. So this, again, Siddharth showed this slide, okay? So where we think that HLA matching is doing a good job, and the worse the mismatches are, then you have inferior outcome. But it is actually from 200,000 patient population that you are seeing this playing in this graph. You and me, never in our 10 lives are going to do 200,000 transplants. What we have been doing like 500 or 600 or maximum 1,000 transplants, okay? So, and even this thing, the 0 antigen mismatch did fine. And if you critically look, 1 to 6 antigen mismatch, there is no much of a difference, okay? Even having 200,000 patients. So this is what, again, I think Siddha showed this one. So this is a single center from Manitoba in Canada. So where, again, just 600 patients, but they have a follow-up for like 12 years. And we all know that zero antigen mismatches in class 2 really is a very good thing. And they did fine. But between two DRs and two DQs, we had like 1 to 4 mismatches, the difference of which was they were not able to tease out even after following up for 12 years. So when the same data was populated to the eplet mismatch, what they found was that increased eplet mismatches had an inferior outcome. So this is so the second thing that we fascinate about the epitope, So, so as a clinician, what is the take home today? What I can do best for my patient with the available data, okay? And so I think Professor 𝐸𝐿𝐴 has to give the whole credit for making, he was speaking about this for the last 20 years, and the last 5-10 years, this is coming up in a very big way, and he was a visionary from that standpoint. So a lot of tools have been developed, okay? And I'm just playing with one tool of the 4 or 5 tools available right now. So basically, the yellow one is the antigen, and basically an antigen, so B cell is an antigen presenting cell. So B cell goes and grabs up the antigen. So there is the red spot is, for the antigen, there's a B cell interface that we call it the B cell epitope. And the whole B cell processes and gives it to the T cell. At that time, you get the antigen has got a T cell epitope interface. So basically, people have developed different tools based on these epitopes because we have the 3-dimensional structure of these HLAs, and it's very, and the new typing, high resolution typing, people were able to tease out, which are these epitopes, and they have developed multiple calculators based on this thing, which are like computer generated this thing. But all these tools need a high resolution, 4-digit or 2-field typing to populate the real epitope data. So I will just walk through the HLA applet registry, which everyone can use. It is a free-to-use software. You need not have access to this thing. It doesn't slow down your computer. The previous one, HLA Matchmaker, it's used to slow down your computer a lot. So this is one thing that everybody can use. Just Google HLA applet registry, then this page will come up. And basically, it is actually a big directory. It has all the epitope data. It is basically owned by a Brazilian consortium, but they are doing a great job. So we have all the epitope information, and you have an epitope which all antibodies has it. Antigens has it. That info is it's a complete directory, I would say. And okay. So basically, you have to have a high-res typing, and we populate this thing into the HLA applet registry. So you Google down, you get the HLA applet registry. It goes into this thing, go to the mismatch calculator, click on the mismatch calculator, then you get like multiple options. The one thing that you can do is to go to the multiple donor options, and you have to enter your HLA in the patient and in the donor areas in the way they have mentioned. There's a prototype that they have given which you have to follow, otherwise it will not generate an output. So I've entered the patient and the donor data. You just press calculate, and it gives you the applet mismatches, okay? So this has got 18 applet mismatches in class 1, and class 2 they have DRs, DQs, and DPs separately, and you have like 14 in class 2, and total you have like 32 applet mismatches. Again, you click onto it on this patient versus donor, then it gives you which all are the applets that are mismatched. Okay, these are the mismatch applets. And of that, you can see certain things in parentheses. These are the antibody verified applets. Okay, now we click onto that 41T or something, then it will populate and say which all antibodies that it should develop. So if you are reacting to an epitope, if you are reacting, many times you need not react. Even if you are retransplant patients, only 50% you need to develop antibodies. Okay, so suppose you develop against an epitope, it should follow a pattern. Okay, so that pattern is important. We'll go to that. So suppose you have got multiple donors. I put all the donors. If with a single press, I can get all this applet information. Okay, against 3 donors, which I got first donor, I got 44 mismatches with 36 with second and 20 with the third one. And we think that 20 is a better one. We don't know. So As a clinician, I think these are the 3 areas or 3 points where we can rely on epitope with the current evidence. One is that suppose you have got multiple donors, we will discuss it. We can say that, okay, this is one area where have less eplet mismatch might be a better one, but let's see what the data is. Second is, suppose you have an antibody profile. Naturally, you might have developed an antibody when you have reacted against an epitope, okay, a eplet, okay. So that should befit some eplet pattern, okay. If you get an eplet pattern from your antibody profile, that gives life to your antibody profile. Because just like Mohit discussed, it is a very sensitive platform. You can throw up any number of antibodies just like that, but it doesn't make any clinical correlation or sense. And third is that suppose you are going for a retransplant. I know I have developed antibodies against my prior transplant, means some epitope or some eplet in my prior donor have inserted some resource. So if I know that eplet which have been immunogenic to me, I can avoid that eplet my future donor. So just to get an idea how much of a memory I have to cross, I think epitope can be useful. So coming to the first one, this is where the whole literature is. Almost 90 to 95% of the literature on epitope is based on which say that increased eplet mismatches means it's this inferior outcome, okay? So it's basically retrospective registry-based studies and quantitative studies where the, like a registry means like 100 to 1,000 patients. So big question is that in a prospective transplant, as a clinician, you and me, when a patient comes and says that, okay, I am sitting with my mother as a donor who has got X number of eplet mismatch, is it going to affect your clinical decision making? So the answer is that we don't know, okay? So we don't have, so suppose in the same data that I showed you, we think that the 20 eplet mismatch is a better donor, but there is no data to substantiate that in a prospective way, okay? And so this is again the same paper from the Canadian group, because it's a very good paper because of the long-term follow-up. Even what they found was that the effect was only in class 2. The class 1, they did not find any big difference. And there is, and another thing that they could debunk was that the concept of, we all think that one antigen mismatch is better than a 2 antigen mismatch. But what happens is what they showed was that with an 1 antigen mismatch, there could be a high eplet load. And with a 2 antigen mismatch, you can have a less eplet. So that's how they debunk the concept of antigen matching concept. Okay, that is one thing that came from this paper. And there is another paper, this is again another big paper, almost 900 patients, follow-up for almost like 8 years, and from Belgium. And what they found was that only DQ had some effect on this long-term outcome. Having a B or C or even DR couldn't tease out any difference in their long-term outcome. So these are clinical points as a clinician that we can take. So again, if you go back to the old paper, they have a follow-up paper in 2015. And what they found was that having an increased eplet mismatch, even in class 2, they had an inferior graft survival only when they had a non-adherence, okay? So the only thing is that increased eplet mismatch at class 2 is bad, but the thing trips if you become non-compliant with immunosuppression, okay? And so to add to that, there was another study, it's a bold study, 𝐶TOT9 study, okay? So it was a very bold paper. Actually, they had few patients, they did transplant, everything was fine, antibody-wise naive, immunologically naive patients, they did transplanted, had some surveillance biopsy at 6 months and everything was clean. They dared to take the tacrolimus off. Okay, tacrolimus is the best, we all agree that it is the most important drug. Okay, they took tacrolimus off and they found that almost 30% had refractory rejection and graft loss. Okay, and when they looked at it, what they found was the increased eplet mismatches. Those patients who had increased eplet mismatches had this problem. Okay, so having an increased eplet mismatch means it is a subgroup where you have to be careful. That is the only take home that we can have with the available evidence. So increased, that only in class 2. So increased eplet mismatches in class 2, DR and DQ, more data is on DQ. That is a high-risk population where you have to be careful with immunosuppression. It's not a group where you can play with immunosuppression that much.
So these are the take-homes. I'm just repeating. So as for a clinician, you can, suppose you have got multiple donors. I'm coming with my 3 sisters, or both my parents are willing to donate. Then you can initiate a dialogue. See, with your elder sister, you are having a less 2 class, eplet mismatches, and that's it. You can just initiate a dialogue and just say, okay, this is the evidence, so you have to be compliant with the immunosuppression if you are going with this donor, but otherwise it is not going to be an arbiter test, and and this has been reciprocated across the different tools that we have. Now, second is the single antigen bead profile. So I told you it's a very sensitive platform. You get antibodies just like that. And at the end of the day, you have to put some life into that antibody and take a call based on whether you have to transplant or not, okay? So this is one patient, okay, this is the patient is the wife and donor is the husband, naturally. So she has developed antibodies. Naturally, she has developed antibodies because through pregnancies, she has been sensitized by her husband. So this has to fit to some epitope in the donor. That is the concept, okay? So what we look is that we took, put both patient and donor in this calculator. You get the mismatched eplets. So you have these mismatched eplets in class 1. So one of these 10 is the culprit who have instigated this antibody, or need not be one, it could be multiple. That's the trick here. So what we found was that if you look at this, out of the 10 eplet mismatches, these 4 can explain this antibody profile. Okay, so if you critically look into it, these are 44 km, 163 Rg, and 80 TLR is the most important one. Suppose I have 144 Kr, I would be okay with that. So this is how we expand the donor pool, just like Siddharth discussed in the morning, okay? So you know which all the epitopes that you should avoid. If you are going to avoid everybody, you are not going to transplant this patient. Suppose I am calling a cutoff here where I have got 44 Kr, that is going to, land up you in trouble. Because if you look at 44 Kr, it has reactivity, it doesn't have that reactivity. So I would ignore these antibodies even it is like higher MFI, okay? And so this is it, okay? And so it is basically, so to give life to your antibody profile, you have to know your sensitizing event. That's the trouble that we have. Many times we don't have the details of the prior transplant or husband's HLA typing or, blood transfusion. That's a big challenge. Now coming to the third thing, it is to give an idea of how much memory you have to cross. Suppose I have a failed transplant, I'm going for a retransplant. So suppose I have developed HLA antibodies. So suppose I don't have antibodies, I'm good enough. Okay, you can just go ahead just like, just like that. But suppose I have I have an antibodies against my prior donor, then I should know which all are the eplets to which I have reacted to, and I should try to avoid that eplets in my future transplant. So this is a patient who has come for second transplant. First, I think father was the donor, okay? And now you have got antibodies out there. So the patient is sensitized. So we should look, what has instigated this antibody response, and we put again into the calculator. We know which all are the mismatches. We have so much mismatches, eplet mismatches in class 1, so much in class 2, and we have to tease out. So if you go and click on 41T, it gives you the antibody profile. So from that you can tease out which is the culprit, okay? So these are these things. So what we found was that 144 TKH gives all these antibodies that have popped up in the antibody profile, and 698E gives the class 2 antibody. So these 2 epitopes I should avoid my future transplant if possible, okay? So this is it. So just to sum up, I think with the available evidence, increased eplet mismatch in class 2 DQ is something that if you have donor options, okay? If you have like multiple donors, okay, prospectively you can see. Suppose it's an old transplant patient, you can look at your DQs and you can retrospectively say that, okay, you have a high DQ mismatch, you are not a candidate whom I can play with your immunosuppression. Suppose some people might come for decreasing immunosuppression due to financial reasons or something. I think there you can use this tool for tailoring your immunosuppression. And that is no high risk population where you cannot play with it. And second is that to give life to your single antigen profile and how much of a memory you have to cross in your future transplant. So at the end of the test, it is not an arbitrary test. Okay? You can give some sort of a risk profiling. I think I thank my mentors and the whole team. Thank you all.
Thank you, Feroz, for that nice and thought-provoking session. So just looking at the clinical utility of this eplet mismatches. Probably, as you said, in case of when you have multiple donors, okay, to select a probably right donor, that will be helpful. And what is the clinical utility in a case of a deceased donor transplant program?
Okay.
Where you have, you have one donor and multiple recipients. So to select a recipient who is appropriate.
Yeah, I think, George, in clinical practice, I think Praveen asked the same question today morning, you know, what will you weigh, whether it is single antigen bead or will you go for a, this thing. So I think for a decision-making process, still cross-match is the final thing. I think Dr. Handu will agree. You do the flow cross-match, if it is negative, 85% of the patients are done with. I have to have only a headache of 15% of my patients whom I have to like tackle. Suppose it's a sensitized patient, you are, in Kerala if you take, you know, I think Noble can agree, if you take the Kerala wait list, our topmost patients are there for a long time, they are sensitized, they are not going to get kidney with the rate of donation. At least in those patients, you can profile them, you can say at least to find, so in Calicut I know, I have the topmost patient has got all antibodies against DR, except DR7. So unless anything at DR7, she is not going to transplant. I mean, that's an extreme case, but there are sensitized patients top in the wait list. I think with profiling them, we can say that this is okay. Just like I told you that patient, you know, suppose it's a little more broad, and I find that all 44 kTH can be avoided. So I think you can profile these patients and take some. So you have to have enough donors. So apply to work, you have to, the patient in contention should be a sensitized patient. If the patient is not sensitized, and the patient has a cross-match negative, I think we need not, as in India, we should not worry about that population at all. Don't wait for, you know, suppose I am a 25-year-old guy, my mother is 45, you know, how can we take, you know, you have a DQ mismatch as 30, you cannot be transplant expert Canadian. So it's zero utility for us, okay? If you are sensitized, the broader you are sensitized, okay, you can play with these tools to facilitate a transplant for him. Otherwise, disease donor, cross-match negative, put the kidney and go ahead.
Great talk, Feroz. And if I take the clinical points rightly, are we moving from unacceptable antigens to unacceptable epitopes?
No, madam, no. So that is why I told you, I don't know how, I am using epitope only in two circumstances. Once some retransplant patient comes and I have all the donor data, then I will sit and see, okay, here I got to get another maximum, so long-term outcome. Second is that in paired kidney donors come, certain voluntary donors come. They come to facilitate a transplant, like might be AB recipient with the old donor. Then I just look, they are not at any disadvantage. Suppose they might be luckily between a very less epitope mismatch, by doing something good, they should not be at a long-term disadvantage. Other than that, madam, this is a tool. If you want to decrease your immunosuppression, okay, you can look and say, okay, we are, as a clinician, we are forced to decrease immunosuppression at some point for all our patients.
With a lot of epitope mismatch, we should not go for TAC lowering. We know that TAC lowering indiscriminately also.
And that only in class 2, that would say, madam, with available data.
That much also be the clinical point to take ahead.
Yeah.
Is it available free of cost, the applet calculator?
Yes, ma'am, that is the one that we all can use, HLA applet. All others, it is like, has got some vendor. First you have to pay, others you have to have, the vendor should have supplied. Applet registry is the super one, madam. You can use
and we have to upload only HLF high resolution?
Okay, basically, you have to populate high resolution data, but majority of this thing you can impute and find. For your patient, you can impute and find. It's not 100% okay, but it can.
The discussion is open to audience. Yes.
Sir.
Feroz, can epitope spreading, that phenomenon which occurs in autoimmune diseases, can it occur in a transplant scenario?
Yes, sir. Definitely, it can happen, sir. So all the concepts, actually, previously used to say about the 𝐄𝐩𝐥𝐞 and all. It's nothing but epitope. You have the same epitope being spread across different alleles. 85% of the epitopes are like spread across more than 5 to 6 alleles. So that is the difficulty with epitope. So if you are going to just go by this thing, you will not be able to transplant anyone. Praveen. Not that much, you know. Even if you look at the PRAs, what Mohit was saying, you know, okay, madam's paper says that it is actually high resolution data, it might be, but need of a high resolution is not like, you know, it might be like 20% of our population. You know, with the available data, if you suppose you have a antibody against DR04 and DR014 and you don't have DR1405, then that's okay. You know, you have at a serological level, you have a response. At the level of, you know, having a antibody at a very epitope level is much less. That's what epitope data shows. And these people have created the single antigen bead thing with a representation of applets in mind. That's how they have selected these beads.
Nice, Feroz, great talk, nice. I would like to have a question, like you must have seen a lot of antibody profile in sensitized patient. In your experience, what is the sequence of sensitizing events, whether it's pregnancy, second transplant, or blood transfusion? Which one will put in order?
So there's a lot of evidence on that. The blood transfusions, it's like a 20, 40, 60 rule, okay? Blood transfusion around 20% gets sensitized, pregnancy around 40%, and retransplants around 60%. And the thing is that there are a couple of things to add on to that. The tendency to have this antibody response sustained, that is also less for blood transfusion, a little more for pregnancy, and a little more for transplant. But suppose I am sensitized with blood transfusion, and suppose I have a A1 antibody like 10,000, irrespective of whether it is due to blood transfusion, pregnancy, or it has the same value. Hope I am clear.
This one more for us. Yeah. So in future, do you think we can use applet matching for, say, disease donation?
No. Definitely no. Answer is no, Satish bhai.
Nothing.
No. Cross-match, flow cross-match is where we should invest. That's what I would say. At least in the near future, in our lifetime. Yeah, so one thing that I showed, you know, so it gives you the whole bucket list of applet mismatches. So in that, one in brackets, parenthesis is where you have more evidence that it has developed antibodies. But we have seen certain applets which has not been antibody verified, but has shown to have our antibody profile favoring that.
So that means
it is a moving goalpost. That is another drawback of epitope.
So that
Tomorrow
means
we come with more epitope. Yeah.
That means to say that the applet mismatch by itself, in the presence of SAB, without single antigen bead, you might be able to categorize or risk stratify the patient. Is it?
But you know, Jitu, the question is that, I mean, you have a patient in front of you. You have to transplant the patient. So do you have enough data to take a decision on the transplantability with that you don't have? And the way the things are going, it's not going that direction as well.
So you can risk stratify, but not...
Yeah, you can. Suppose you want to decrease with your immunosuppression, okay, that makes sense.
Thank you, Feroz. Thank you once again. As we are running short of time, we'll